Hi, good afternoon, everyone. On behalf of Wellcome Trust DBT India Alliance, THSTI, IAVI, and Nature India, I would like to welcome you all to the third webinar on COVID-19. Thank you for joining us this afternoon. I hope all of you are doing well and are taking good care of yourself, your loved ones, and your community. As we sail through the COVID-19 pandemic, we deeply value the role that journalists, community reporters, and media professionals are playing to keep the public informed about this crisis. These uncertain times require us to interpret and communicate information on COVID-19 accurately and speedily, with a collective responsibility to reduce public fear and panic that is caused due to unavailability of credible information and spread of misinformation. It is with this view that we have put together this webinar to give you an opportunity to ask the questions to the experts, questions that matter, and the ones that have been keeping you up at night. Thank you so much for sending in your questions for the panelists. The webinar is 90 minutes long, and we will try to take as many questions as we can. We request you to ask questions related to today's topics, which are COVID-19 prediction models, current status of vaccine R&D, research opportunities for India, and the social and economic impact of the outbreak. A little bit of housekeeping before we start the webinar. The webinar will be recorded and will be shared widely. At any time, if you have questions, you can put the questions in the question box on your right. The views of the speakers are personal and they are speaking from their position of being an expert. This doesn't represent the view. They're not speaking on behalf of the associated organizations. The webinars would be recorded and, as we mentioned, shared widely. I would like to thank our speakers today for agreeing to do this webinar on such a short notice. We have with us Dr. Gagandeep Kang, who's the Executive Director of Translational Health Sciences and Technology Institute. Dr. Gagandeep is a medical scientist who's is a key contributor to the understanding of diarrheal disease, rotavirus epidemiology, and vaccinology in India. She became the first woman working in India to be elected to the Royal Society of the UK last year. She's also the chair of the National Technical Advisory Group for Immunization and vice chair for the Coalition of Epidemic Preparedness and Innovations. Thank you so much for joining us, Dr. Kang. We have with us Dr. Menon, who's a professor at the Ashoka University. He is currently the professor of physics and biology at Ashoka University and on leave from the Institute of Mathematical Sciences, Chennai, where he is the professor in theoretical physics and computational biology groups. He is also the adjunct professor at the Tata Institute of Fundamental Research. He works in mathematical modeling in a range of fields, including disease modeling. In addition to his scientific interests, he is interested in science outreach, science policy, and communication. A very warm welcome to Dr. Menon and Dr. Kang. Thank you so much for agreeing to do this. I'm going to take up some burning questions that we have as questions start flowing in. The question for you, Dr. Kang, is, we've seen a lot of papers recently coming out talking about a slew of papers appearing on talking about vaccines. Especially there are papers which talk about the protective effects of BCG, a TB vaccine that is given to healthy babies in India. I want you to sort of clarify for us what is the status of a vaccine and how effective is BCG vaccine?
So there are two separate aspects that relate to vaccines for COVID-19. One is to use existing products, and the second is to see if we can get new vaccines made. Since the new vaccines are specific, let me take that first. In terms of projects to develop vaccines, there are about 90+ projects that have been initiated around the world to develop new vaccines. And these use a number of different kinds of technologies, some old technologies like making an inactivated virus, or having components of the virus like the spike protein, or adding on other components of the virus as well, and new technologies that allow you to respond rapidly and make vaccines quickly, which include the messenger RNA vaccines, using both direct as well as self-amplifying RNA. There are vector-borne, viral vectored vaccines that are also being made, and DNA vaccines. So every new technology that is available for making vaccines is being applied to making vaccines for SARS coronavirus 2. In terms of where we are with those many vaccine efforts, we have 2 vaccines that are in human clinical trials already. One is a vaccine from a company called Moderna, which is an mRNA vaccine that started trials a couple of weeks ago. The other is a vaccine from a Chinese company, CanSino, and that has also just gone into human trials. That's a protein-based vaccine. And they're trying also a virus-like particle approach. 2 other companies will be going into human trials this month, and it's anticipated that another couple of vaccines will go into human trials in May or June. So we are moving very rapidly with developing specific vaccines. In terms of the burning questions around BCG, a lot of that is based around a study that shows that countries that have high rates of BCG vaccination seem to have a slower spread. I would argue that the countries that have high rates of BCG vaccination, by and large, are also the poorer countries in the world where there is a lot less testing going on and where it's likely that we are at an earlier stage of the epidemic. There is another argument for BCG, which is that we know that BCG has specific and non-specific effects on the immune system. So some work done by Mihai Nitia has shown that there is a concept called trained immunity, which is when BCG channels your immune function a certain way, you may respond to viruses very differently when you see them in later life. Now, that is biologically plausible, also given that BCG is used as almost an immune therapy for bladder cancers. So it's a plausible hypothesis, and there is a reasonable correlation at this time. That correlation may change with time, but I would like to see results that come from individual level data rather than these population-wide studies. Now, for individual level data, I'd like to see cases and matched controls. So essentially, people who have had COVID-19, who are matched for age, sex, socioeconomic status, location, travel history, pretty much everything else. And you show me then that people who got COVID-19 infections or severe infections had lower levels of BCG vaccination than those who did not, then I'd be a little more convinced. What would be still more convincing is results from the randomized controlled trials that are being initiated around the world in healthcare workers mainly. But these trials are going to look at the effects of BCG vaccination to see whether it prevents infection and severe disease in people who are given the vaccine or not given the vaccine. Some of these trials are BCG alone, some are BCG with influenza, and with the other arm getting influenza alone. So I think the readouts from these trials is what will convince us finally that BCG works or does not work.
Thank you so much for that, Dr. Kang. While we are at it, I wanted to also understand from you, there is a lot of discussion that has happened that the Indian strain of the new coronavirus, the SARS-CoV-2, is weaker. Also, Indians have higher immunity. I've heard similar claims being made even for the African population. You've sort of hinted at that. If you could help us understand this a bit better.
Okay, so in terms of the strains, we have sequences of 2 strains from India. And those 2 strains, I wouldn't call them Indian strains at all because they were derived from people who came back from Wuhan early in January, so pretty close to the start of the epidemic. So you're not going to expect to see those strains being very different from what was coming out of China at the same time. In order to understand where the strains are evolving and how they are transmitting within communities, we need to be sequencing every strain we can lay our hands on. And the most recent strains are the ones that will be most informative about what has changed in the virus. The second thing about Indians and Africans being a special breed with special immunity, I don't buy that at all. This is a virus that the rest of the world has not seen before. So in terms of infection, we are all susceptible. If you haven't been infected before, which is most of the world, we are susceptible. What is feasible is that maybe we had the infection much more widespread in the community than we know if it came in early. But the only way we are going to have answers to that is to do proper seroepidemiological studies, which we haven't done so far. So right now, there is no evidence that Indians or Africans are actually more immune to this virus than anything else. One of the arguments that is brought up quite frequently is that we are exposed to so many different things that our immune system has become better able to handle this particular virus. Well, we are exposed to many things and we make an immune response to the things that we are exposed to. If this virus we have not been exposed to, then we are not going to be immune to this. There is potential from a very small study that people who have had either SARS or maybe MERS coronavirus, but more likely SARS, might have some degree of cross-reactivity with this particular virus. Not so much for the spike protein, but the nucleocapsid. Well, there were only 8,000 people who got SARS. So those 8,000 people among the survivors, the almost 90% who survived, those people might have some level of immunity, others don't.
Thank you. Thank you for clarifying that. While we are at this, I wanted to sort of probably bring in Dr. Menon and understand from Dr. Menon. Dr. Menon, you've been doing a lot of work in the modeling. We read the article that you published today, and sort of borrowing from that, I wanted to understand from you if you could help us understand in terms of modeling, where exactly is India headed? What are the models apart from the SIR variants and the SCIR to model infectious diseases? Which one is better compared to, between the two, and what appears to be most realistic for India, and why, if you could help us understand those?
Yeah, I mean, models for infectious disease really rely on this idea that's about a little less than a century old, that you can subdivide the population into various compartments: the susceptible, the infected, the recovered, maybe the exposed, and you can add further compartments. You can subcompartmentalize these. For example, the infected could be a mild infection or a strong infection. The stronger infection could go into another compartment, the hospitalized compartment, etc. But the idea that you can take your entire population, take every individual and put them into one of these buckets and really look at the flows between these different buckets as someone gets recovered after being infected is a very deep and profound idea that's expressed in mathematics, but it's really an idea that is in words and you can think about it separately. So regarding models, the SIR model is among the simplest models that you can think about. And it was the original model that was devised by the people Kermack and McKendrick, who devised it and used it to first describe the plague epidemic of 1906 in Bombay, and showed how well their mathematical model fit the real data on the epidemic in terms of the number of cases every week. Right now, I mean, Kermack's and McKendrick's work went unnoticed for a long while, and it was rediscovered in the 60s and the 70s. And now that really forms the backbone of how we think about modeling infectious diseases from multiple points of view. And to an extent, your model has to reflect what you know about the disease. There is no modeling independent of the disease. Every disease carries with it its own model requirements that you must have. Because for SARS-CoV-2, we know that there is a substantial period in which you are exposed, in the sense the virus is building up in your body, and then only then do you manifest symptoms, which happens about 5 to 6 days later. But during that initial exposed period, you're capable of infecting someone else. And this has been, in a sense, this has been known for other examples as well, except that the exposed period has been fairly short in that case. It's typically been a day or 2 days. So this is an example of a case where you can have a fairly long exposed period before you actually manifest symptoms. And some people may in fact go straight from there into becoming immune to the disease without really going through a period of being symptomatic. And exactly how important this particular sequence is really unclear at the moment. It could be as much as 80% of people really don't manifest symptoms at all while being able to infect other people. So that's this exposed category. As I said, this depends upon the disease that you're trying to model. And certainly for SARS-CoV-2, the existence of an exposed category is almost mandated by the data and what we know about the disease until now. If you ask about, so given a model, there are approximations that go into building the model and thinking about it. The simplest version assumes that every person in India is equally likely to contract the disease. They're equally likely to, to contact someone who is infected by it. And thereby, if they're susceptible, then they can get infected in turn. The problem with this is that this is a large country, and we know that the main flows that have taken this in have been from Wuhan, from the Middle East, a few from Italy, etc. They've all been initiated by people flying in through airports and really going to states that, for example, Maharashtra, Bangalore, Kerala, etc. So these are, on the other hand, the far east of India or other states which see less of this traffic might be expected to have fewer cases and less exposure overall. Were actually introduced. Right. So we should think about this as really very diverse in terms of space itself. It's not just one country where everyone has an equal chance of being infected. We should worry about how this is distributed across the different states of India.
Right, and I think based on this, I wanted to sort of understand from you, what is is there some model that you can sort of pinpoint at and say from your experience that this is where the trajectory seems to be going like as of now? And apart from SIR and SEIR, are there any other models that we should be looking at or India can refer to?
I think the SEIR model would be the basic model, but the only question would be, are you applying it correctly? Are you really thinking of India as just one homogeneous mass? Or should you worry about it at a much more local and micro scale, in terms of which the patterns of transmission of the disease can be very different? In very dense regions, for example, concentrated slum areas in Bombay, there just is a lot more contact between people. People are in far closer proximity. So it's easier to transmit a disease, especially a respiratory disease in that context. In a remote rural area of relatively low density, the chances of being able to pass the infection on are correspondingly reduced. So it's this sort of variation that you need to worry about. There's the variation between the cities and urban areas and the rural areas. That's again a sort of point at which you can have very different ways of probabilities of transmitting the disease from someone infected to someone susceptible. So the next level of modeling, the important level of modeling, would be to include these effects, to actually include modeling at the state level rather than the all India level, even within the state, distinguish between rural and urban areas, maybe isolate the different cities in the state as points where you can transmit more efficiently compared to relatively low density rural areas. That would certainly be an improvement on the current model, but starting with the SEIR is a sensible thing to do.
Right, thank you so much, Dr. Menon. I wanted to sort of understand from both of you that, there have been some super spreader events that we have seen in the recent past, and in that context, what would the predictions look like? Will we see an actual impact happening in the spread of infection because of these super spreader events, be it the mass exodus of migrants or religious congregations or other mass gatherings?
So I could start first from a more virological perspective. So one of the things that we need to try and understand is how much a person sheds. And the variation in shedding can be log orders different between different people. So a person who is shedding, let's say, 10,000 particles when they sneeze versus somebody who sheds over a million or 10 million particles when they cough or sneeze is going to be very, very different. So super spreaders, for some reason, we don't seem to be able to identify early enough the kinds of people who are likely to turn into super spreaders. What's special about them? I don't think we really know this at this time, but there is something that where they effectively mess up Gautam's models. He has to figure out ways of handling how to include potential super spreaders. What would be really useful for us is to know what proportion of infected people would turn out to be super spreaders, and that's something that we really have no information on at the moment. So I'll stop there and let Gautam take over.
Yeah, no, I mean that's a very good point. Exactly that. The only thing that we shouldn't demonize super spreaders. They're sort of part of the natural variation of the presence of the virus in somebody. Super spreaders are exactly as Gagandeep said, hard to account for in the sort of simple models that I described. There are somewhat better models. For example, network models that say that the ability of someone to infect a lot of people depends upon where they are in the middle of a network of people they have contacts to. So you could argue that this is one way of putting it in. It's certainly one level additional of complication over the simple SEIR model. Super spreaders are probably more important in early stages of the infection because they give it the initial kick to take off, and a little less important later on when the infection has already taken root in the community. And as I think Gagandeep has said, and as probably I will also emphasize, unless you test, you don't know to what extent it has actually taken root in the community. So we don't know where we are along that curve, and that's really an important point to emphasize.
Thank you, Dr. Menon and Dr. Kang. I'm just going to pick up some of the questions, and some of the questions with regards to modeling that are coming are, how to account for imported cases in modeling, and how do we need to include testing factor in models as well, which you've already sort of answered, and the SEIR model output depends on number of initial infections as well. Can you explain how to choose the number of initial infections while modeling for the state?
Yeah, that's a hard question, but in general, the point with these models, and in fact the point with epidemics in general, is that you just need to start it off once, and then the internal logic of the epidemic will take over. And that's essentially what these models predict, that there is this quantity called the reproductive ratio, which is a sort of shorthand for the approximate number of people that one initial infected person will infect. So if you say that one person infects 2 people, those 2 people go on to infect another further 2, so that's 4. So you have the sequence 1, 2, 4, 8, 16, 32, 64, which sort of blows up pretty rapidly once you have. But really, you need only one person to start it off with. And once you're into that flow, then the logic of the epidemic takes over. There's no stopping it at that point. And then you have to sort of think about other methods, such as social distancing, identifying cases as early as possible. And that is crucial. Once it sort of takes root in the community, then this business of finding contacts, tracing, etc., becomes much more difficult than it would have been at an earlier stage. So at least the fundamental logic is that once you start it off, it doesn't matter if it's 1 or 10 or 20, etc. That number will grow. And the SEIR model, as I said, is a good starting point for thinking about it.
Right, thank you. I want to bring in Dr. Kang and sort of try and understand from you, Dr. Kang, that while we've sort of acknowledged that testing is important, and Dr. Menon has also emphasized on the need for testing while we are predicting better models, can you help us understand what types of tests do we currently have in the country? Are they fast? Are they cost effective? What better can be done in that space?
The tests that we have in the country as of a few days ago were basically real-time PCR-based assays, which look at nucleic acid amplification. You're taking the RNA of the virus, pulling it out of the virus, making a DNA copy of it, and then multiplying that many, many times so that you can see whether the sequence that you have generated is the same as that of the virus or not. So it's a technique that has been around for decades now. It's very widely used in infectious disease diagnostics. Recently, there's been a lot of news about also having antibody tests available, and antibody tests. So while the RT-PCR is essentially detecting the nucleic acid of the virus, the antibody test is detecting the host's immune response to the virus. So these antibody tests only become positive once a person has been infected and has had time to respond to the virus. Usually you will start to see the first antibody, which is IgMs, comes up between 10 and 14 days after an infection. It goes up for a couple of weeks and then starts to decline. So in some viruses, it may be completely gone 4 weeks after infection. About 3 weeks after infection, you start to see another antibody called IgG. That antibody comes up 3 weeks after infection, but then can persist for many, many years. Now, whether these, so in terms of measurement, when you start to look at which test should you be using when in order to identify whether a person is infected or not, the RT-PCR test becomes positive 2 days before a person becomes symptomatic. So before they have a cough or fever, you can do a nasal or throat swab and find that they are positive. Now, obviously, this isn't done because we tend to test only when somebody has symptoms. This test will stay positive on an average of about 2 weeks totally. So maybe by day 12 or so of symptoms, this test will start to become negative. In some people, it will become negative earlier, and in some people, including people who sing, it can last a little bit longer. So I believe that Kanika Kapoor is positive on her 5th test, and that is not unusual. You do have a very long tail of the distribution of how long people can continue to be positive. It doesn't mean necessarily that she or anybody else who's shedding virus is still infectious at that late after infection occurred. In terms of the antibodies, there is absolutely no point in using an antibody test in early infection. You cannot find antibodies just after you have been infected. The first 10 days, very unlikely that you will find any antibodies. So if you take the median time to symptoms as being 5 days, you could argue that 1 week after you have started to have symptoms, you could consider looking at an antibody test, but the test that you do must measure for IgM antibodies at that time. If you use an IgG test, that is a signature of prior infection, but will not become positive for at least 3 weeks after you got infected. So IgG tests are really good for seroepidemiology, for population level studies, for trying to understand what proportion of the population has been previously infected, but they are not useful for acute diagnostics. But it's also important to remember that while RT-PCR tests can be set up quite easily and are very specific in that they don't have false positives, they are based on a sequence from the virus. With any kind of serological test, the test needs to undergo considerable validation before you understand its use case. Right now, a lot of the tests that are coming onto the market, we have no idea how well or badly they perform because they are being released under something called an emergency use authorization, which means they have not undergone the kind of rigorous testing that is usually required of a serological test. So what I would say for serological tests is you need to understand what you're using it for. You need to understand when you need to sample, and you need to interpret those results with great caution.
Thank you so much, Dr. Kang. In the context of the serological surveys that ICMR has recently announced, there have been questions where people want to understand what are the other steps that the government is taking to map the scale of COVID-19 outbreak at the community level. Have states started community surveillance of influenza-like illnesses? How will such surveillance take place if public health centers and outpatient departments and hospitals are not functioning currently? Do you have anything to suggest on those?
So in terms of expanding surveillance, I think a very rapid sero survey would be the best way for us to understand what is happening. But we must understand that the sero survey done must be repeated at very short intervals to show us where and how the infection is progressing in the community. So a first rapid sero survey followed by adapting a design to be more informative for future sero surveys is very important. In terms of what states are doing for ILI and SARI kind of surveillance, some of the states have started to do much wider testing, syndromic testing of patients. And obviously, so mostly states in the South so far. I think one of the things that we are not exploring at the moment is what is coming out of the private sector's testing. I think that is a very valuable source of data, and we should be looking at how we can integrate that into anything that we put out as estimates of disease burden and estimates of disease location. During the lockdown, obviously, all kinds of surveillance get thrown out of whack because it isn't possible to do many kinds of studies that you would otherwise be doing. But this is a time that we should be planning sensibly for what we can do in the future, whether it is during the opening up or future lockdowns or however we approach it, we need a plan in place right now. I'm not aware of exactly what ICMR's plan is, but I'm sure they'll do something sensible.
Thank you so much, Dr. Kang. I'm just pulling up some of the questions that people are asking online. So one of the questions is that I read an article on pool testing being a more cost-effective solution considering the constraint of having enough kits. Is this advisable? And in addition to that, one question is, can any sort of strip-based diagnostic test be developed based on microarray principles?
So let's take the first question, which is around pool testing. Absolutely. Pool testing is very valuable in the early stages when you don't have a lot of positives. So if you pool samples and you get negatives, you can say, okay, I don't really need to worry. There are different approaches to pooling. One is pooling from a clinical perspective. The other is pooling from an epidemiological perspective. So if you're pooling from a clinical perspective, and this is what they are doing in Germany currently, which is to take a bunch of samples, put them together, keep one extra sample, and if all the samples are negative, there's nothing more you need to do about it. But if one pool turns out positive, then you go back and test the individual samples and figure out who's positive or not. So that is clinical testing. And for epidemiological testing, what you can do is use mathematical formulae that allow you to create from a set of samples multiple different pools, so that you test a restricted number of pools and get an understanding of what percentage positives there are within the original samples that you came from. It's very difficult to go back to the individual level, but you will be able to go back to the entire population and say with some degree of confidence that we don't think we have missed a lot, or that we think that there is a lot out there.
Right, thank you so much. And I want to come to you with a question where, there are a lot of questions coming on the lockdown, and we do understand that there is a need for lockdown and its adoption as a global response in terms of helping flattening the curve. However, in the context of LMICs, and especially for a country like India, which has very complex realities and informality is sort of a part of our national fabric in some ways, in terms of job, in terms of living arrangement, mobility, healthcare. For many here, stepping out of home is not a choice. It's a daily requirement. It's a daily need. And in that context, could we have adopted or done, or is there something else apart from lockdown that could be done, that can be innovated as a strategy, or if there are lessons globally that we can learn?
So I think we are going to need to think about graded approaches. It's not possible to shut a country down for 6 months, and especially a country that is as large as ours. We do need to think about what can be done in which kinds of places. So the ones that are at highest risk need more intensive strategies, whereas where you have a low risk, where you have the capacity to be able to test and trace and isolate, you should follow those approaches. A lot of this needs to be informed by real data on the ground, and mathematical modelers such as Gautam will be invaluable in helping us design such strategies and measure their impact. So I'll hand off to Gautam for the rest.
I mean the general question is really it's a very hard one to answer. Was the current lockdown justified? In my opinion, yes, based on what we knew about what was happening around the rest of the world. It's a hard choice to take, and you could argue that we should have been better prepared for it in terms of certainly the more vulnerable sections of our society. You could certainly say that. What happens in the future, as you know from my article, that's very hard to predict. I think really the only way to tell is to have a model that you trust, or models that you trust, and hope that they're all pointing in the right direction. I agree completely with Gagandeep that some sort of graded restoration that is depends also, it's not the same throughout the country, but is very conscious of differences in local regions, is probably necessary. And at least what we know is we're almost certain, or at least it seems to be fairly certain from the point of view of modeling, that at the end of the lockdown period, cases will go up if they don't go up continuously throughout the period of the lockdown for reasons that are for other types of reasons. So then the question is, can you have some sort of light bulb mechanism that the moment it crosses a certain amount, then you impose a condition again, then watch for it to go down, then you impose it once it begins to rise up again. And you have to have really good data to be able to enforce something like that. And that's very important. But you can also do this locally. You can do this state-wise or district-wise, depending upon what data you have about these regions. And somehow I think that may be the best that we can do. But we'll have to see what combinations. Also, some combinations of strategies might work. It's not clear what they are at the moment. But certainly pulsing your strategy, lockdown, break, choosing the amounts correctly, choosing when you switch from a break to a lockdown might really be the sort of one solution to this question.
Gautam, on the lockdown, can there be a surge of infection once the lockdown is lifted? China has gone for doing that partially. Is that the right approach, is one of the questions that we see coming.
I think most models that you see would predict that you will see an increase at the end of the lockdown. And I don't think there's any way of getting, as I said, epidemics have their own logic. They don't, that you do have, as long as you have susceptible people in sufficient number, and as long as you have people to infect them, that infection will spread. And if you were able to do an absolutely superb job of during the lockdown period, finding and isolating all infected cases, then that might have been a way of potentially tamping it down a little bit more. But the big worry here is that, of course, you may not be detecting most of those cases because they don't show symptoms. If you're not detecting 50 to 80% of the cases because they're asymptomatic, but they can transfer the infection, then that sort of puts a whole question mark on this exercise of how effective you will be at the end of the lockdown period. I know this doesn't sound very hopeful, but in a sense, this is what models are saying. And there really is no reason to doubt that this is what will happen based on what we know about how epidemics spread.
Thanks, Gautam. I'm going to take one more question on this. It's basically is asking, while we need more lockdowns in order to break the infection cycles, what do models suggest about the capacity of lockdowns to be able to break the cycle? And are we going to see more frequent lockdowns? Is there a second wave of infection or a threat of second wave of infection that we should be worried about or anticipate?
So as I said, any way of enforcing physical distancing between people, we call it social distancing, but I would prefer to call it physical distancing because that is probably a little more appropriate, will help you reduce the number of infections because it just breaks the chain of transmission at some level. It reduces it to in-household transmission if you make sure that these households are separated from each other. So any sort of strategy that enforces such distancing is a positive in terms of the spread of the disease. On the other hand, you have to ensure that the disease actually goes to zero before you lift the lockdown. If you can do that, then that lockdown would have been effective. But it's impossible to do that because the amount of time you'd have to wait to enforce that particular strategy is just too long. And there are too many ways in which even very, very minor violations of this, any little bit of mixing that reduces the amount of social distinction can spread that disease even further. So I'm sure government is looking at models, and I hope they will be looking at combined models that combine various things. I'm sure hope they were looking at more local models rather than global predictions for India. I think that really is the way to go. And that's where modeling should help. Based on what I see now of the modeling work, it does seem as though we will have to have more lockdowns. One lockdown will not solve this particular problem, but the intensity and the nature and the period of those lockdowns, hopefully there will be more planning for. And as always, the people we have to worry about are people who are really the most disadvantaged parts of society. And that to not take their interests into account when we do this, to ensure that their livelihood, their interests, the sustainability long term would be criminal. So I do hope that whatever policy government thinks about keeps that in mind.
Right. Thank you so much, Dr. Menon. I'm seeing some of the questions coming now on the malaria drugs and the usage of malaria drugs as a potential treatment for COVID-19. And the question is that from the perspective of Indian researcher, what needs to be done in the area of repurposing of these drugs? What Indian scientific community is doing regarding treatment of the disease? Dr. Kang, would you like to take that?
Sure, happy to take that. So in terms of using chloroquine, at least it's biologically plausible that chloroquine could work. But in terms of having sufficient data to be absolutely confident that it does work, I'm unconvinced at the moment. So everything is pointing in the right direction, but we really don't have the data to make a policy decision on that yet. The WHO has started a study which is called the Solidarity Trial, which is comparing 4 different treatment arms. One of them is hydroxychloroquine. And hopefully within a couple of months, we'll have an answer whether chloroquine works or not. There are also other ongoing clinical studies. Much of the data that we are relying on has come from China and from France. And the French 2 studies, the first one was a small sample size. The second one was a slightly larger study in about 80 people. The Chinese study was also relatively small numbers. They are helpful. I understand that it's difficult to do a high quality clinical trial with lots and lots of different kinds of outcomes in the context of a pandemic when you're clinically really overloaded. But right now, the evidence is insufficient to make a clear call on whether hydroxychloroquine or chloroquine should be used or not. The other thing that is interesting is these 2 studies were regarding hydroxychloroquine as a treatment for people who had severe disease. There is also a study that is being funded by the Bill and Melinda Gates Foundation that is looking at hydroxychloroquine as a prophylactic. So while the Indian government has made a recommendation to use it as a prophylactic in healthcare workers, the study is only just starting to be done. And when we have data on that, I think it people will be a little more convinced that this is the right approach. When you are in the context of a pandemic and there is a lot of fear, there is a kind of approach of wanting to try anything that is possible for a treatment, because if you think that it might work, then it's worth trying. But it should be tried so that the data is informative to other people. So the Solidarity trial, for example, is one excellent option for gathering a lot of data from around the world very quickly. And I hope that we will make sure that everybody in India who has patients with COVID-19 has the opportunity to participate in that trial.
Thank you so much. One question that seems to be coming up always is, what is the effect of high temperature on the spread of COVID? Will it reduce the infection? Can you please clarify? We have like 3 or 4 people asking this question to us right now.
So in terms of, if you really want to kill the virus, you have to go a lot higher than 45 degrees, right? So, but that's the same for flu. And with influenza, we do see some level of seasonality. It's not like influenza is killed, it just circulates less in summers. Now, why is that? Is that because people are not in closer contact with each other? Is it that the virus doesn't survive very well in the environment? Well, there are lots of explanations for that, none of which are 100% contribution to the seasonality. So if this turns out to be a seasonal virus, we will find out shortly because our temperatures are rising. But at the moment, I have no reason to believe that temperatures will affect the spread of this virus. It's spreading in the UAE, which has much higher temperatures. It's spreading in Pakistan. It's spreading in the southern part of the country, which is currently hotter than the north. So I'm not sure what we are going to see, but I think the coming few months will tell us.
Yeah, I just wanted to add to that when it's summer in the northern hemisphere, it's winter in the southern hemisphere. So you could have an oscillation between the north and the south. It's potentially, I mean, these are all the interesting things that could happen with seasonality. We just don't know at all.
Right. Gautam, I also want to ask you, where exactly are we right now in terms of on the graph? Are we still peaking, or are we moving towards a more flattened curve? Where is India headed right now is the question coming.
If you look at the number of cases, they're sort of resolutely going up, and it's certainly showing no sign of flattening. Really, if until now, I mean, it's now about 10 days, I guess, since the lockdown was imposed. By now, you might have expected over the last maybe day or two to have seen a little bit of flattening. That isn't happening, but still these numbers are too small to really make a statement. And just the fact that you may not be seeing the cases because you're not testing enough to find out who's infected. So we really don't know. And so I think I think it's a little too early to tell. The overall trajectory of the number of cases seems to be a little different from what you're seeing in, for example, in the US or in Italy. Seems to be somewhat flatter. And if that is really the case, that is good, because it suggests that the reproductive ratio is actually a little less than what you might have thought it was. But is that real or not? We really don't know. I mean, to what extent this is an artifact of the fact that you're not counting cases enough, we don't know. So I would hesitate to make any strong statement about that at this point.
Right. Thanks, Dr. Menon. One of the questions that we are getting is plasma of recovered patients for treatment. Is it something that's viable?
So I think from what, so I won't say 100% right now that I know that it is the perfect treatment for coronavirus infected patients. it does again appear likely that it will be helpful. There is a Chinese report that just came out. There are ongoing studies in the US. So doing plasma therapy or doing apheresis, getting plasma out. So you can do it for one patient, you can do it for 5 patients, depending on whether you're doing it as a single unit donation or doing it as separating plasma out from an individual and putting the red cells back in. So these things are very plausible. They have been done for other infectious diseases in the past. So there is potential for these kinds of therapies, particularly for patients who are heading on a poor trajectory. But in terms of being absolutely convinced that this is the right way to go, I think this is another of those things where we need to approach this carefully and with the right kind of planning. You need to have a screening protocol in place because you don't want to do more damage than good. You want to see that the plasma that you're giving not just is plasma from a recovered patient, but it's the right kind of plasma in that it has antibodies that will prevent the action of the virus. So whether that is going to be neutralizing antibodies to the virus, which are not usually measured when you measure antibodies, that we have to figure out. And many of the studies that are being done now are doing that.
Thanks. We have a question for Gautam here. Gautam, in absence of extensive testing, can we make a comparison of percentage positives per number of samples tested across other countries?
The answer would be no, because you're not testing enough. So it's hard to compare those. I mean, there are sort of mathematical techniques that allow for that degree of uncertainty. That say that, suppose if you have load testing with whatever numbers you have, can you incorporate that uncertainty into measures that tell you what the true number of cases are? There are those, but again, there are uncertainties even in those calculations, and to an extent, you have to put them in from outside, your measure of that uncertainty. So there is really no way other than having good data. I mean, your models and what your models will tell you are only as good as the data that you put into them. If there are very large uncertainties in that input data, you should not trust what comes out of the model.
Thanks, Gautam. There's one more question that comes from Tamil Nadu, which says that wouldn't surveys of asymptomatic individuals at randomly chosen localities and or hotspots, for example, in Tamil Nadu during this lockdown, be helpful for developing some models? What's your take on that?
The answer is yes, but I think they probably will have to be serological surveys rather than RT-PCR, because you want to detect whether the person has had the infection at some earlier point at all. And as Gagandeep emphasized, you have to wait at least 15 to 20 days after the initial infection for that to show. So if you want to look at background levels of people who have been infected in the past and then recovered, the sort of methodology that you would use would be different, because once a person has cleared the virus from the system, you won't pick it up in conventional tests, the RT-PCR. So certainly that would be true, but I don't think we have those capabilities yet at large scale, if I understand that right. Gagandeep, would you like to just clarify that?
No, I think you're right.
So we have a question: is COVID-19 airborne, and can you clear the confusion around the mask?
So it's what you define as airborne. Yes, definitely COVID-19 is airborne. Now, whether you're talking about it being transmitted through large droplets or small droplets or practically virus by itself is what the question is. All of these are mechanisms of airborne spread. And initially, we thought that airborne spread was what was the major route of infection. It appears that that is still the case, with droplets being spread from person to person. Now, the small droplets that come out are really what we call aerosols, and there are certain kinds of procedures that generate aerosols. So doing intubations, doing anything that has a flushing mechanism can lead to a flushing suction, will give you aerosols. So in hospitals, aerosol generating procedures are done a lot. We've recently had a study using the virus and showing that the virus can spread up to 20 feet away. Now, while that is done in an experimental setting, whether that is the case when people are generally walking about and shedding a certain amount of virus, we don't know how important it is to move that 6 feet of separation to 20 feet away. It does appear that it's likely that it isn't only coughing that is responsible. It may be people speaking very loudly or singing, which is data that came from a choir in Washington, that spread can happen. So both distance and making sure that you have some protection of your mucosal surfaces is important for preventing any type of airborne transmission. And washing your hands is important for the third type of transmission, which is through fomites. And those fomites are also generated indirectly from airborne transmission because the droplets will fall and land on objects, land on your hands, and then you use your hands to touch different areas, and those are then potential sources of the virus. So ultimately, yes, this virus is absolutely airborne transmission, droplets, smaller droplets or aerosols, and fomite. Fomite is just an object.
Thank you. Thank you so much for clarifying that. And I know there's one more question which we have taken in our previous webinars, but it keeps coming on the Chinese roots of this virus. Is it now confirmed this virus is China-born? Do you want to help clarify that?
So does it matter?
Yeah, I'd agree. Does it matter? Is certainly the question to ask. The thing is that we do know that 3 out of 4 emerging diseases are zoonotic in origin. So they will happen whenever you have ecological situations where you put humans and other organisms together, animals together, that really shouldn't be in close physical proximity. So I mean, I think in a sense, people understand that the settings in which this disease jumped to human beings, it's spilled over to human beings, were natural settings for this to happen anyway. So if it hadn't happened now, it would have happened later. It would have happened maybe somewhere slightly differently, but that's just, I mean, in a sense, it doesn't really matter now.
I'd like to take that in a different way as well. So some families of viruses jump species more easily than others. We know now with 3 examples in the last 20 years that coronaviruses do this very easily. Now you have a lot of coronaviruses that are in domestic animals. And there is no predicting when the next coronavirus is going to jump from an animal to a human. It's not necessary that this needs to be an exotic species. So while, if you have multiple different species, you will have multiple kinds of viruses that they carry. And if those species come in contact with humans, you may get animal-human transmission. We have to remember that this can happen from domestic animals as well. So viruses that are in cows or chickens or, many of the other species that we link with very closely can jump, and we need to be aware of that.
Right. Thank you for clarifying these. I wanted to ask you both actually that, a lot of public response that we are seeing to COVID-19 right now, a lot of it seems to be stemming from fear and prejudices leading to stigma. And also in some instances, it sort of blends with lack of trust on the public health system or on healthcare providers and vice versa. Uh, and we have learned it from the past epidemics and in general that, you know, without community support, we won't be able to achieve much. We've seen this in the context of polio. We've seen this in the context of HIV. What can we learn from our past experiences? What kind of messaging needs to go out now to create that enabling environment where people feel safe, they feel okay to get tested, they feel okay to seek healthcare, and at the same time, the healthcare providers also feel safe?
So there's multiple aspects to your question. So maybe I'll start and then ask Gautam to take over. So in terms of what it takes for this virus, way more than for polio or for anything else we've seen so far, community participation is going to be key. Every person needs to commit to doing what they can to help slow the spread of this virus. It's the only way that we are going to have enough of a response to be able to not overwhelm our healthcare system, which is fragile as it is. So asking the community to step in, to do their part is absolutely essential, and that's the messaging that we have seen. What I don't know about, and I think getting clarity on this is important, is how much penetration does this message of community responsibility and individual responsibility have? Is it really reaching the people who are the most vulnerable and most in need of protection? Now, usually those are the people that are ignored by our society most of the time. They are the people who find it most difficult to access healthcare and are really the most vulnerable in every sense. Health, economics, you name it, every problem you can think about, they are more likely to have. They are also populations that are more easy to stigmatize. So if somebody there gets infected, not only are they a part of society that's already not respected, this is going to stigmatize them anymore. So this is a really complex situation. And we have to understand that people who are infected are not evil. They are victims. And we need to recognize that they are deserving of every kind of support and care that we can offer to them and to their families. Because, in fact, we'd be very selfish in doing that, in giving them support to be isolated, because we are doing that to protect ourselves. So, very important to ensure that every part of the community understands what this is about and what we need to be doing about it. So I have a lot more to say, but I'll hand off to Gautam and maybe we can come back.
I really can't improve on that answer, except that to say that I think this element of the fact that if you look that ensuring the interests of someone else, especially someone who's disadvantaged, protects you. And that exactly as you said, I think that's an important message to give, that in a sense that the whole community is concerned about everybody in the community. And the health of everyone is the health of any single individual is an important thing to communicate. And as you said, I don't know if that message has gone out yet. The second important point, and again, I'm not an expert in this, is that trust in a public health system is built up over years. And distrust in it is not something that you can cure in a day. So messages about the fact that you can trust the public health system to work in your interests and be available when you need it is something that one has to constantly message. One has to keep in mind that you have to build this trust, and you can't do it in a day. I don't know if that's a satisfactory answer to anything, but it's certainly something that occurred to me.
I think one of the things that's really important in building this trust is for the government not to try to do it itself. Because in many areas, they don't have the reach that many community organizations do. So this is a time to be thinking about how do you bring everybody to the table? How do you utilize the strengths of different parts of society, of different organizations, as much as possible to get the messaging out there, to really truly build the community. And I would argue that this is also a time to make sure that we build a primary health system that communities will then trust. It should be the preferred place to go when you are sick, whether you are rich or poor. And many countries have this in place. We should be thinking about building that now.
Exactly.
Thank you so much for those insights. I think we've been constantly talking about the need for a more interdisciplinary approach and the need for all hands on the deck right now to sort of deal with this situation. I also want to throw at you guys trying to understand that, what extra measures can patients who are living with life-threatening conditions like cancer, tuberculosis, HIV, can they take at this time? We completely recognize that these people are more vulnerable in a situation like the COVID-19 infection, and what steps can they ensure that they have access to uninterrupted care in this situation?
This is going to be a challenge. So when a healthcare system gets overwhelmed with acute cases, people who have chronic conditions will get short-stripped. So preparing for that is very important. Maybe we will be lucky and maybe it won't happen. Maybe it won't happen everywhere. But being in control of the management of your illness is very important. So for those who are immunocompromised, making sure that they are protected from infection is critical. And for that, you need to think about all that we have heard about physical distancing and staying away from people who might be potentially infectious. Then the other thing to be prepared for is for shortages. So if you are on certain kinds of medicines, try and put in at least as long a supply as you can manage. I'd say at least 3 months, if not longer, so that you are not caught short when there is something like a lockdown or your hospital or your healthcare provider does not have services in place. If you have a chronic condition and you require acute care, this is the time to be communicating with your healthcare provider to let them know that these are the concerns you have and figure out if they have pathways. That way you will know what to do and where to go if there is any kind of an emergency. And these emergencies need to be stratified in two ways. One is if you think that you are infected with SARS coronavirus 2. The other is if it is an exacerbation of your current condition or any other acute condition. The management of both of these will be very different and hopefully will be done in different places as well.
Thank you. We have a question for Dr. Menon. Dr. Menon, given that the data for the models are mostly from Western countries or some data has come in from China, how applicable are they for India? Also, given the trajectory of COVID-19 in India, can these model or parameters be adapted to the Indian context, or is there too less data yet?
I think the general consensus is that the disease is a disease that's caused by a virus that we haven't seen before. There's no particular reason to believe that its trajectory and how it's described, the numbers that describe it from China or from Italy or from New York, should be any different from the numbers that describe it in India. Barring unusual circumstances that we really don't know, for example, what the effect of BCG, does it have an effect, etc. We don't know that. So I don't think there is a problem with applying those numbers that we have learned from the Chinese experience or from the Italian experience. I think those epidemiological numbers are probably reasonable. We should ask instead, to what level do we know about the Indian situation in terms of people who have been tested for the disease? What are the relative fractions within the population? because that's what we need to compare to. That's a number that we really need in order to do modeling. But the other inputs that come from outside India, I don't think one should think that the Indian situation should be really very different from that.
Right, and in line of that, another question that has come is, what are the efforts that the government is currently doing to use the data from the quarantined individuals, either those who have traveled themselves or have come in contact with those who did?
The short answer is that we don't know. At least I don't know.
Well, I get my news from the newspapers the same way that you do. Essentially, we know of the isolation processes that the government has in place, the quarantine being done for travelers. And more recently, we had this report of hotspots being identified. I'm not really clear on how those hotspots were determined, but maybe Gautam has more insights.
No, actually, I don't. And this is interesting because this goes to a general point about what is the role of a government to communicate, a public health system to communicate during an epidemic. And I would argue that they have an absolutely primary responsibility to communicate, because this information is vital for anyone who wants to think about it from any sort of quantitative point of view. Not only that, to sort of, for example, not hold regular briefings, not update your numbers on a regular basis, really threatens the flow of information that is required for people to even begin thinking about this. So I would think that more transparency, more availability of information is actually crucial. Exactly as you said, what happened to these patients, what has been tested, what is the status of testing, what is the status of testing of patients who report with SARI or ILI? Do we know about that class of patients? What fraction tested positive from the numbers? I don't think that that data is really available.
Right, I absolutely agree that there is a more need for transparency at this stage to manage the epidemic. We are flooded with questions. I'm going to quickly jump on to another one. Is there an antibody available right now that we know for COVID-19? And also, at the same time, if you could talk a bit about the fecal-oral transmission, what do we know about it right now?
In terms of antibody tests or antibodies for treatment?
I think it's for treatment. It is for treatment, yes.
Okay, so antibodies for treatment can be considered two ways. One way of treating infectious diseases is to give people antibodies from a person who has had infection before. So these are hyperimmune sera, or the kind of plasma therapy that we had spoken about previously. These come from recovered patients. Sometimes you can make hyperimmune sera in animals as well, and then use those for treatment. But what is new and exciting is the potential for now making monoclonal antibodies that might be useful for patients. Now, you can make monoclonal antibodies many ways. You can take the protein, you can immunize animals, you can then figure out which antibodies are the ones that are the functional antibodies that you want, the ones that block the virus, and you can humanize those antibodies. So doing antibody engineering is a big deal now. The other way of doing it is to take patients who were infected and take out the cells that make antibodies, then figure out whether they are making, which cells are making the antibodies and what kinds of antibodies, figure out which ones are making the useful antibodies, then you can sequence the genes that code for those antibodies, you can clone them, and you can create essentially a factory that makes human antibodies. Now, these human monoclonal antibodies that are derived from recovered patients might then be useful as treatment or as prevention. Now, whether we can make them cheaply enough or we can make them in enough volume to be able to treat lots and lots of patients is an outstanding question. But given how far technology has come in terms of both our ability to do these incredible things but also to change how things are manufactured. I'm really hopeful that we'll get to it pretty quickly. Whether this pandemic will be what drives innovation in this field or whether it will be the next one, I don't really know.
Thank you so much. I wanted to understand from you, have we seen any cases of mother-to-child transmission? We know there was a paper that was published, but we exactly don't know what has been happening on that front.
So there's been a lot of interest in pregnancy and infections in pregnancy and what they mean for children and whether children are infected or not. The numbers are not very large. So one study had 38 women who were pregnant. Another study with deeper sampling had only 3 babies born of pregnant women. And one child certainly was sick with respiratory symptoms, but recovered after 3 or 4 weeks. There have been other studies that have sampled multiple samples from pregnant women, amniotic fluid, breast milk, placenta, looking at serum, and really haven't seen what looks like direct transmission of the virus to babies. It's quite possible that this might happen. A lot of viral infections, when mothers are infected in late pregnancy, can be transmitted to their babies. The reassuring thing, well, I can't say reassuring because the data are really very small and we don't know. So far, we have very, very, very few reports of children getting severe disease and dying. There are reports. An infant died in Chicago recently, but mostly we are not seeing a lot of this. So the general advice is continue your pregnancy as it is. There is no need to do a cesarean section. If a cesarean is required, then the surgeons are advised to have very gentle procedures so that aerosols are not generated, both for the mother and the baby, but also for the people who are in the operating room. After the baby is born, there is no need to isolate a COVID-19 positive mother. And if you're thinking about breastfeeding, that is to be encouraged. The only thing is that if the mother is well, she should be practicing, limiting respiratory spread. She should wash her hands, wash her breast, and make sure that she's wearing a mask around the baby. If the mother is unwell, or you could also think about expressed breast milk, and if the mother is unwell, you could think about donated milk from a bank.
Thank you. Thanks a lot. I'm going to give both of you probably 3 to 4 minutes each to, if you guys can sort of highlight what are the research priorities right now for India and globally that we need to prioritize.
I'll start first and give Gagandeep the last word. So I wrote this article in The Wire that came out today about models that had been used, typically models by scientists working abroad to understand India. And I've been asked in that context, where are the Indian models? Where are the people working on this? Aren't there epidemiologists and people studying this in India? Why don't we hear from them and what's happening? At least on that front, I think within the next week to 10 days, we should have really good models coming out of India that improve on the other models that I mentioned in various ways, but are probably a little better informed in terms of what we know about Indian conditions. The point that I made in that article, and to make more generally, is that you should not think of a model as being a static object. A model is something that has to be constantly improved. A model is something that people provide input, say that this is the wrong approximation, this is the wrong assumption, put this in, change that, let's see what happens. And that way, that is the only way we can get to better and better models. And this is absolutely crucial to understand. And we should look now both really realistically at the short term to ask over 3 days, 5 days, what do you predict, as well as longer term. But longer term is always much harder to predict than the short term. So let's see if we can get our short-term predictions right for these models with these improved models. and they will give you a much larger degree of granularity than the other models that I was discussing. And hopefully, I think there will be work of quality that one can really refer to and use as an anchor point when we discuss this from the modeling perspective, and I think that will be really valuable. Go ahead.
Gautam, I'm sure you have a lot more research priorities than just better mathematical models. But I think if we are to think about what we need to do for research, one is the research that is related directly to understanding disease. Mathematical models are obviously part of it, but there is a lot more clinical research that needs to be done as well. The questions that were asked about pregnancy, the questions about asymptomatic infections, why are teenagers infected or not as symptomatic as older individuals? What determines severity? What determines outcomes in people? Who are the people who are 93 years old and get well when you have 56-year-olds die? So how do you understand the trajectory of disease better? What determines that, I think, is critical. And then you need to understand, at the individual clinical level, but also in communities. And the first community that you see is individuals and who they are interacting with, who spreads, what determines a super spreader, as was asked before. But then look at hospitals. In hospitals, if healthcare workers are at greatest risk, what needs to be done in their environment to make sure that they are appropriately protected? Are there ways in which we can think about even something like cycling healthcare workers? What's the best approach to make sure that other functions of a hospital are not affected while you are handling COVID? So there's all kinds of things that need to be done. And then, of course, there is the research on therapeutics, on diagnostics, on vaccines, all of which are critically important. In India right now, I think diagnostics is the need of the hour because, as we've repeatedly said, without testing, you can't understand what is happening to the disease. So we need to use every tool we have to advance testing as much as possible so that we focus our efforts on the best control that we can do with the tools that we have already. I'd be happy to talk about therapeutics and vaccines, and all that needs to be done, but I think that is really for a later date.
We also have a lot of young researchers who have joined us on this call. And if you guys can throw a little bit of light on what is it that the young researchers can focus on right now.
I'm part of various groups. There is a group called InSciCov, which is based of a bunch of institutions between sort of Chennai, Bangalore, Bombay, Delhi, Pune, etc., which is really composed of scientists who are contributing to various types of communication about the disease. So there is an effort made to papers relevant to India to try and summarize them in a simple way. Material, for example, what sort of material instructions can you suggest to non-formal workers that to the sort of whole informal sector in India, how to properly do social distancing if you work in a small sari shop or something? What should you do as opposed to if you work in a big office where certainly there's a lot more information about what. So how to customize that information for different regions in the country, how to translate it, how to make it available, how to make short public service announcements regarding COVID-19. So they're welcome to join this effort. It's a community effort. Everyone does it together. And I can sort of emphasize that, or whichever local region that they're in, there are groups of scientists working on this. And I think certainly an important part of it is just communication and to work with grassroots community organizations to send the message out about the need for community involvement. I think it's crucial at this point, exactly as Gagandeep said. And it's certainly the responsibility of a scientist to do something like that. It's part and parcel of what comes with being a member of society.
And if I was to add to that, in terms of what they can do is, there are a lot of science institutions in the country that are focusing on different areas of innovation. So whether that is in personal protective equipment or that is the development of drugs or vaccines, there are other groups out there that are looking for participants, and you should be looking at how can you be part of a bigger effort in addition to doing what you can for society as well.
Thank you so much. It was so great to have you, Dr. Kang, and you, Dr. Menon. We're very thankful to you for agreeing to do this on such a short notice. There are more questions coming in, but I guess we might have to send these questions to you over mail. And I really want to thank both of you for taking time out to do this webinar. It was very insightful. We are learning each day as we are learning to deal with this with COVID-19. And I do hope that by the end of all this, we all turn out to be more human and more empathetic. And we are struggling, but we are all learning. And I hope that all of us do take good care. We do hope to hear from all the participants about what they felt about today's webinar. We do plan to host a few more in this series, and the feedback would be very, very valuable for us. We have put together a FAQ sheet online that probably has been shared with you in the chat box. The sheet is updated after each webinar, so please do keep an eye on it. And if we have a little request, if there are people who can help us with translations of these FAQs, please do drop us a mail on public.engagement@indiaalliance.org. On your screen, you can see a list of resources that you can look at in case you want more information. Thank you so much, everyone. Please do take good care of yourself and your loved ones. And thank you to the team that has helped in organizing this. I do want to give a shout out to Sarah, Yukti, and Hina from India Alliance, and Shirley from THST, and Shubhra from Nature India, who have helped us organize this. A big thank you to all of you, and please do take care of yourselves.
Thank you.